Hi, everybody. My name is Erin Burke, and I'm in my last semester at Merrimack College in the Masters of Athletic Training program. Today, I'm going to be talking about a case study that I saw in an athlete who had a tibia and fibula fracture and ended up with compartment syndrome, and this all resulted in a drop foot, which I'll get into in a couple minutes. So, a little bit of background on the case. At the time, the athlete was a high school senior, and he was playing his final season of football. He was otherwise healthy. He did have some knee pain from a potential meniscal tear, but he was playing through it because he didn't want to be out for the season. He was committed to play Division I football the following fall, and he, in the middle of a game, got hit in the lower leg and had some mild deformity, but his chief complaint was severe right leg pain following the blow. So they referred him to a hospital where he got x-rays, and it was concluded that he had a closed tibia and fibula fracture. At the time, there were no signs of compartment syndrome. He was brought into surgery, and the tibia was secured with an intramedullary rod, and after the surgery, he had normal range of motion and normal levels of pain given everything that he had just been through. 2 days post-op, he began physical therapy, and he had some short-term goals, which involved performing bed mobility without the use of a bed frame and being able to sit and stand with the least amount of assistance. He is a very independent athlete, so I'm sure this constant assistance wasn't his cup of tea. He wanted to be able to ambulate 150 feet without assistance and also ascend and descend stairs with a BUE support, which is pretty much just an ankle device that holds your ankle into dorsiflexion to support you while going up and down stairs and just ambulating around. So after this session, he complained of severe leg pain and swelling. And so they did a bedside compartment pressure reading in his lower anterior compartment, which read 60 millimeters of mercury. Just as a reference, the normal is about 10 to 30-ish, and he was reading 60, so that's double the maximum amount that you could have in the compartment. And he also was suffering from anterior compartment muscle weakness. So they rushed him into surgery for an emergency fasciotomy. Across the next 9 days, they debrided the necrotic tissue from the anterior compartment, and he ended up losing about 60% of his anterior tibialis due to just continual necrosis and debridement. So that left him with 40% of the strength for dorsiflexion in his anterior tibialis, and this resulted in drop foot. So about a year later, after doing physical therapy at home, he came to our care at Merrimack College, and the initial evaluation was as followed. He had 1 out of 5 for a manual muscle test in right ankle dorsiflexion. This means that he couldn't even get his ankle up to neutral against gravity or just assisted. He had negative 45 degrees of active dorsiflexion, so he couldn't even get his ankle to neutral again. We took some girth measurements of his lower leg. His left unaffected side was 42 centimeters, and his right affected side was 36 centimeters. He had a noticeable gapping over the fasciotomy site. He had a very large scar over this site, so it was very easy to see where the anterior tibialis was when it was firing. He had some muscle cramping in the gastrocnemius. As you can imagine, being unable to dorsiflex his ankle left him in almost a constant state of plantar flexion, so that gastrocnemius soleus complex was pretty tight. And he also had a noticeable drop foot in gait and was with a normal gait, and was compensating with his glutes and hip flexors. If you look at the graph down at the bottom, I found this in a study by Blokovic et al. And this is pretty much a study that the patients had drop foot, and it analyzed their gait secondary to this drop foot. So the C, or the darker boxes, are normal people, no drop foot, and the white boxes are the people with the drop foot, and how big of a difference you can see in the compensation for that comparably to the two. And if you look at hip flexors, there's probably the biggest difference there, which our athlete was exhibiting a lot of compensation with that hip flexor and glute. So pretty much right along with what the research shows for those with drop foot subsequent to other injuries. So with that being said, we really wanted to focus on normalizing his gait and making sure that he was dorsiflexing his ankle as much as possible and not having to compensate with those hip flexors and glutes when he walks. So in order to do that, we use some modalities and a various pileup of exercises. So for modalities, we used Russian electrical stimulation to promote that strength and endurance in the anterior tibialis. And we also used instrument-assisted soft tissue mobilization to really release that gastroc soleus complex to allow him to have the flexibility and mobility to dorsiflex. In terms of rehab, this was kind of one of the earlier rehabs that we did with him to kind of get the ball rolling on anterior tibialis strength. So we'd start with a stationary bike just to increase that cardiorespiratory fitness. We'd do three-way ankle, where we do eversion, inversion, and plantar flexion. And then we do a dorsiflexion 5-second hold to really promote that endurance in the anterior tibialis. We would do some single leg balance on an AirX and single leg cone taps to kind of facilitate that proprioception and balance, as well as stability in the entire lower leg, but also that endurance in the anterior tibialis. And then we also did monster walks both forward and laterally to strengthen those hip flexors and glutes, and also to be able to maintain that dorsiflexion was a big goal in those, so that the body would know to dorsiflex and not just rely strictly on the hip flexors and glutes. And we also did eccentric calf raises to teach that gastrocnemius to let go as the patient is dorsiflexing. This was overall a very interesting and unique case. I'd never seen anything quite like it in my time as a student. And it was definitely interesting to see how we could strengthen such a small portion of what was once a larger muscle, and how big of an effect it can have on activities of daily living, sports, and just gait in general. So I hope you found this interesting and maybe learned a thing or two, and have a great day. Thank you.